Thank you so much. A very good morning. Early in the morning, thank you so much, Dr. Vaishali ma'am, for including me in this IC. So I am going to be talking on reining in the runaway Rhexis. It is very, very important to secure this perimeter. Why? Because we have to build our cataract surgery step by step. Each step is very important. And we know that starting well is extremely, extremely important in a cataract surgery. Well begun is half done. That is what Aristotle said. So I'm going to be showing you a few cases of mine wherein there are a few cases where I was able to rein it in, and there were a few cases where I wasn't, and then how I basically tackled them. So I'll start off with this first case. So here you see that it is a very intumescent cataract, and we are debulking it. Once we have debulked it, we know that the lenticular pressure is not that high, and we'll be able to basically get a beautiful Rhexis. What is important is to hold the Rhexis from the edge, keep holding it from the edge, remove your forceps, and then again hold it from the edge, and then you'll be able to get a proper Rhexis in these cases. So here's another case. Again, this also is not exactly an intumescent cataract, but a very hard brown cataract underneath. So what is important in this case is you see that once the Rhexis is started, now there are two sort of scissor mouths that are there like a vampire. So there was one there and there was the other one. So I took the one that was on the outside, I started rotating and making my Rhexis. But you see, once I'm finishing my Rhexis at the end, I make sure that that edge gets included into my Rhexis. Because if I don't include that edge that was created initially while creating the flap of that Rhexis, then that can be pulled by the phaco probe because it's going to be pronging outside. So you'll see that I will increase my Rhexis size right at the end so that that edge gets included into my entire capsular Rhexis. So now I have a complete smooth Rhexis margin that is there. So in a few cases, even when they're not intumescent, you're going ahead doing a normal capsular Rhexis. What you need to do very importantly is sometimes pause. You see carefully what is happening. I'm now recognizing that this Rhexis is going out. Something is not right. This Rhexis is going out. So I will basically pause, I will slow down, and I will make sure that I do a slow motion Rhexis. Now, despite my efforts of pulling it in, it was still going out. So I came out with my instrument, re-injected viscoelastic, and then made sure that the movement of my cystotome is such that the force will not let the Rhexis run out. So you see here, now once I have reached this 3/4 level of this Rhexis, again look at the movement of my cystotome. That movement has to be completely inwards because I have to anticipate that on the other side the Rhexis was going out, so it is probably going to go out on this side as well. So you don't mind making a smaller Rhexis on the other side rather than getting greedy and trying to make a bigger Rhexis. So this is another case here. Again, I start my Rhexis out. I'm going in with the movement, the centrifugal movement that I require. And you see, once I have reached half of the Rhexis, again, I will pause. It is not necessary that I completely finish the Rhexis in one go. I will pause. I will remove my instrument. I will re-inject visco. I will form my AC. And then from here onwards, I use a micro Rhexis forceps, and then a simple straight movement of the micro Rhexis inside will cause this Rhexis to curve inwards rather than going outwards. So you need to basically notice what the movement of the micro Rhexis forceps was. It was straight inwards rather than curving along the Rhexis margin. So in a few cases, you have to live on the edge. So in this case here again, you start the Rhexis. On top, it is going in fine, but here you'll see that it is absolutely right on the edge of my pupil. So the point to be remembered here is, on a lot of occasions, especially when we are starting out, we tend to feel that the margin of the pupil is how big the lens is, the anterior capsule is. But sometimes the size of the pupil can be very misleading. A smaller pupil will make you make a smaller Rhexis, although there is a lot of room that is there outside that pupillary margin also for you to make that Rhexis. So you see in this case here, again, you're starting out the Rhexis. As ma'am mentioned, in this case, you can see a lot of adhesions that are there right at the bottom over there. So once again, you start out the Rhexis, and then once you finished the 3/4 of it, you notice that the Rhexis has gone out. But again, as the point I mentioned on the previous case, this pupil margin that is there right on top, there is a lot of space that is there beyond that pupil margin also for me to go and make that Rhexis even beyond that. So we don't have to get misleaded by the size of our pupil. Even though the Rhexis had gone out beyond the margin, there was still enough space over there for me to rein it back in. This is a case of a traumatic cataract where you can see the markings have been done. So we're planning a toric in this case. Again, you see that the Rhexis is coming right on the edge. The tendency of this Rhexis is to go out each and every time that I'm trying to make that Rhexis. So now right at the end, you'll see there is another way to deal with it. I'm trying again with my Rhexis forceps. I'm trying to rein it in. Now I'm seeing that no, this is not going to be pulled in. It is going out. So what I'm going to do is I'm going to take a scissor and I will basically cut this Rhexis right at the end, because I know most of my Rhexis is already complete in this case. So I'm going to take a scissor and I'm going to cut that Rhexis margin off from there so that I get a nice circular round Rhexis. So in this case again, now I was lucky enough because it was a young patient that I could just go in with my irrigation aspiration cannula, and this central plaque sort of a thing that is there, I am able to push it up. Once it is separated from the side of the bag, then I go in with my epinuclear settings and then I remove this, the plaque that is there. Now this also has a posterior plaque that is there. So once I'm done with my irrigation aspiration, I try to take that same cystitome needle that I had taken in the beginning and try and sort of remove this plaque by tugging away on it. Once I realize that no, it is completely adhered to the PC, then I don't touch it. I leave it like that. Now I'm trying to do this case is a perfect example of a Murphy's law. Whatever wrong has to happen will keep happening in each case. Now this lens has opened upside down and it's a toric lens. So I had to flip it over, and then it is a 4-plate haptic lens. So then I had to rotate it so that it comes onto that angles that I have marked over there, and then I'm able to finish this case. Now this case will have to be yagged later because there was no point of taking that central plaque that is there posteriorly out. So not every single time things go hunky-dory, things go well. In a few cases, what happens is we get extremely greedy. So you see in this case, I start off with my Rhexis. I get a very, very nice round, but yes, very, very small Rhexis. So once I get a very small Rhexis, then I get very greedy in this case. I feel that, let me just enlarge this Rhexis. I'll make a nick and I'll be able to enlarge it. Reason was that when I tried to rotate it, it did not rotate. When I tried to do a hydrodissection and then tried to rotate it, it still did not rotate. So I was very skeptical that, with this small Rhexis and this rotation not happening, will I be able to finish off this case? So you see what happens here. I go in, I try and make a nick. I get greedy, I think that I'll be able to make a bigger Rhexis, and the moment I make a cut, it's gone all right the way through, the moment I've made a cut. Now what I've done is, I've tried to rotate it onto the side so that I can get it, but no, it is completely on the side of that cut only. The reason why this was incorrect was because the cut that I had made was completely straight tangential, whereas the cut that I should have made should have been at an angle, and then I would have been able to rein this Rhexis in. Luckily, I was able to chop this nucleus out. Once the chopping was done piece by piece, I was able to remove the entire nucleus out because I had got enough space on one side of the Rhexis that had happened. Putting in the viscoelastic and then doing my IA again, had to be very, very careful because the Rhexis had got extended on one side of it. I was trying to make it circular on the other, but couldn't. Luckily, I was able to implant the lens in the bag in this case. You feel happy when you finish cases well, so give yourself the gift of done. Thank you.
Thank you, Rohan. Those were some really nice cases and very well managed. I think I would just, I had 2 or 3 things I wanted to say that, like you showed, that if you have a small pupil, with some experience, you do eventually realize that, yeah, this is behind the pupil, but it hasn't gone to the periphery. But still, I have done this many times and suffered, so I would still recommend, if you have a doubt, use either an iris hook and hook up the pupil, If not, at least use some of those Y or V hooks and just make sure that what you are doing movement is within pre-equatorial. You are not going to the periphery. Second thing, if you have a peripheral extension, again whenever you come out, when you exchange instruments, I would inject viscoelastic, ideally dispersive, but because when you're doing a Rhexis, you want a heavy cohesive, particularly in white cataracts, sodium hyaluronate. And if you have an extension, you would want to use some OVD before you bring out or exchange your instruments. And then, like Dr. Om Prakash sir, Dr. Rohit sir has explained, while doing the phaco, obviously you drop your parameters, but you look at whether that margin is flapping or not, the flap sign.
Motility.
Any other comments from the...
One thing wanted to add about Little's maneuver, that even you can use that like 100 degree. You can pull it 100 degree to the extension of the tear, to the line of the tear, and it comes back. And as ma'am rightly mentioned, we can use hooks whenever it is not visible and it has gone beyond the equator. Yeah, and yeah, that's a very good point. Ma'am is saying that we should always fold it, and if we are using viscoelastic, it should not be in the line of the tear, it should be on the opposite side of the flap, so that that can also cause an extension.
In a white mature cataract, Dr. Vasauda has always taught us you start with a small Rhexis, what you rightly did, and try and aspirate as much of the cortex as possible so the lens is not so intumescent. And as you very rightly said, the cut should be at the angle in the direction in which you're going to increase the Rhexis. So what we usually do is we try to remove as much of the cataract through the small Rhexis, and we also implant the lens, and after the lens implantation, then we increase the Rhexis size.
Yeah. In hindsight, I thought that in that last case where the iatrogenic runoff had happened, after that small Rhexis mode made, I could have done a bit of IA. That IA would have removed all the loose cortical matter that is there and would have decreased the lenticular pressure that is there.
Yeah. So thank you.